All right, are we ready? Okay, so to introduce myself again, I'm Dr. Arielle Allen. I am can you hear me okay? I'm a fellowship trained urogynecologist. And so what that means is I do a little bit of gynecology, a little bit of urology, but I don't do all of gynecology or all of urology. Urogynecology is a specialty that focuses on the female pelvic floor. And so that means I do not do well woman exams. I leave all those to my colleague, Dr. Lacey Parker. But I also don't take care of urologic things such as kidney stones or things like that. I leave those to my colleagues that are urologists. So urogynecology is truly treatment of the female pelvic floor and pelvic floor disorders. Two of the most common things that I see are pelvic organ prolapse and urinary incontinence. Due to time constraints, I'm actually going to talk about just urinary incontinence today. But if you guys have questions about prolapse, I'd be happy to take them later. Okay. All right. So to get going, am I good? Okay. To get going, female urinary incontinence is what we're going to talk about today. Let's see. Okay. The prevalence of bothersome urinary incontinence. The key word is bothersome. I know that sounds weird because you're like, urinary incontinence, isn't that always bothersome? You'd think it would be, but there's actually the majority of women, especially if you've had babies, are going to have some form of urinary incontinence. Like it's nearly 100% of us. But not all of us are bothered by it because it can be very, very mild. Doesn't really affect our quality of life. But the prevalence of bothersome urinary incontinence, where it does affect our quality of life, is very high. And the highest incidence, or the age that at which it's the highest is age 50. And it gets up to 80%. So it's very, very common. Let's see. All right. There are actually 7 different types of urinary incontinence a woman can have. I'm going to talk about 3 of them. They are the 3 most common. There's urge incontinence, stress incontinence, and then mixed. And I'll talk about all 3 of those during this talk. Urinary incontinence, as defined by one of our societies in my specialty, the International Continence Society, the ICS, it's defined as the complaint of any involuntary leakage of urine. So when you're not wanting urine to come out, it comes out. And then 2 out of 3 women suffer from urinary incontinence on average. Okay, so urge urinary incontinence. The ICS defines it as the complaint of involuntary leakage of urine accompanied by or immediately preceded by the feeling of urgency. It's the gotta go, gotta go. You feel like you have to go to the bathroom. All of a sudden, your bladder starts to leak before you can get to the bathroom. And you're like, well, I knew I had to go, but I didn't know I had to go that bad. That's urge incontinence. The common symptoms, like I was just saying, is leakage associated with the feeling of urgency. It's that gotta go feeling. Women will complain of urgency. They'll complain of frequency, like feeling like you have to go to the bathroom all the time. Like, I just went to the bathroom 30 minutes ago. Why do I need to go again? These symptoms can be triggered by certain cues, such as hearing or seeing running water. You walk into a beautiful lobby and there's a beautiful fountain and you're like, well, that's not fair because I need to pee all of a sudden. Where's the bathroom? The sight of a bathroom, even, you're walking down the mall and you see a sign for a restroom. You're like, oh gosh, all of a sudden I have to pee. Why do I have to pee all of a sudden? I didn't have to 2 seconds ago before I saw that sign. That can be a sign of urge incontinence. Keyhole incontinence, or another way of describing that, is called door key incontinence. And that is also super common. And it's when you're driving home and all of a sudden you see your driveway and your bladder's telling you need to go to the bathroom. You're like, oh my gosh, I just left work. I didn't know I had to go to the bathroom. I didn't even feel like I had a full bladder. I see my driveway. I'm driving into my garage and I have to go now. That is door key or keyhole incontinence. It was named because you put your key into the door because you're coming home. You put your key into the door to unlock it, and that's when all of a sudden you have to go to the bathroom. Nocturia is defined by going to the bathroom more than 2 times a night. It's actually considered normal. I don't know who decided this was normal, but 1 to 2 times a night is considered normal. None of us like to get up to go in the middle of the night. I think a man probably just defined that, but it's 1 to 2. I'm sorry for the men in the room. 1 to 2 times a night is considered normal. Getting up more than 2 times a night is nocturia, or the definition of nocturia, and that's considered abnormal and can be a sign of urge incontinence. And then bathroom mapping. I hear this every day in my practice. Bathroom mapping. Does anybody know what that means? I bet you. That's right. Yes. If I had a gift, I'd give it to you. Everywhere you go, you know where all the bathrooms are. That's bathroom mapping, and is an absolute sign of urge incontinence. Okay. Yep. or if you're afraid to go somewhere because you're not sure where the bathrooms are. If it's a new location, you're like, I don't know if there's enough bathrooms. Oh, thank you, Pooja. You're afraid to go places because you don't know where the bathrooms are. That's also a sign of overactive bladder or urgent incontinence and is bathroom mapping. So what are the risk factors? Who gets urgent incontinence? There's a lot of different risk factors. The number one is age and being a woman. So we all pretty much get this at some point in life. Bladder irritants can lead to urgent incontinence. The most common ones are smoking and caffeine. Prolapse, pelvic organ prolapse, again, is not something I'm going to talk about during this talk, but it is also super common and can lead to urgent incontinence. And prolapse is where the bladder falls. You may have all heard of a bladder falling, and that is a form of prolapse and can lead to urgent incontinence. Diabetes, 80% of all diabetics, whether type 1 or type 2, will get urge incontinence. So I see a lot of diabetics in my office. And then any form of nervous system abnormality can lead to this as well, because what causes urge incontinence a lot of times is an abnormality of the nerves that innervate the bladder, are responsible for bladder function. And so almost any kind of nervous system abnormality can lead to urge incontinence. Okay, so moving on to stress incontinence. The ICS defines stress incontinence as the complaint of involuntary leakage of urine on effort or exertion, such as with sneezing or coughing. So I will always ask my patients, do you leak urine when you cough, laugh, or sneeze? Those three. And so if you leak urine when you do those things, that is stress urinary incontinence. The symptoms, like I was just saying, is leakage when you cough, laugh, or sneeze. The risk factors for this are actually younger age. So this tends to be a younger woman's type of incontinence, but that's a terrible thing to think, because a lot of women get stress incontinence no matter what age, and a lot of women get urge incontinence no matter what age. Another risk factor, though, is having more vaginal deliveries. In fact, if you've had 2 or more vaginal deliveries, you're 8 times more likely to have stress incontinence than someone who's had less than 2 baby vaginal births. And also large babies or more difficult deliveries will increase your risk for this happening as well. An increase in BMI or a higher weight can lead to stress incontinence. Chronically increased abdominal pressure, meaning chronic constipation or chronic straining or pushing to have bowel movements, and a chronic cough, so if you've got COPD or asthma. And then mixed incontinence is kind of what you think it would be. It's when one woman has both urge incontinence and stress incontinence. Again, that's not fair to have 2 types, but it's mixed. The ICS defines it as the complaint of involuntary leakage of urine associated with urgency and also with coughing, laughing, or sneezing. It's a combination of the 2. So when coming to my office with complaints of urinary incontinence, you will get an initial evaluation. I will ask you all of your symptoms. I will do a physical exam, and I will check your urine and make sure you don't have a UTI. That sounds so basic, but a lot of times women will come in complaining of these urgency and frequency symptoms, and I check their urine and it's a UTI. So easy fix is an antibiotic. To talk a little bit about initial treatments for incontinence, lifestyle changes. We talk about that a lot. If you're a smoker, I'm going to ask you to stop smoking. And there's a lot of good reasons to stop smoking, but in my world, for your bladder, restrict the caffeine. Oh man, those energy drinks that are so popular, they are causing even girls in their teenage years and early 20s to have urge incontinence. It's because they're drinking those Red Bulls all day long. And then weight reduction, of course, decreasing the intra-abdominal pressure will decrease your leakage. Pelvic floor muscle therapy, I'm just going to touch on this because my colleague here, Sherri, is going to talk about pelvic floor physical therapy in just a little bit in more detail. There is great data to support the benefits of pelvic floor physical therapy for the treatment of most types of incontinence, especially these types, okay? Talking about weight reduction, there was a great study done back in 2005 that showed that just a 10 to 20% weight reduction decreased incontinence episodes by 50%, okay? So it really does help to lose weight. Additional treatments, there are non-surgical and surgical treatments for stress incontinence. There's something called an incontinence pessary, which is a device that you wear in the vagina. I know that sounds weird, that something like that would help the bladder, but they are right next to each other. A pessary is shaped in such a way that it creates a little bit of obstruction at the level of the urethra or the outlet of the bladder to reduce the ability of urine to leak out. That's simply how it works. They do not hurt. They don't cause infections. They're a great non-surgical option. And then there is a vaginal laser treatment that we do in the office. It's also non-surgical. And it it changes the muscle and the nerves that control the bladder, basically, and improves incontinence. And of course, there are surgical options for stress incontinence, urethral bulking, a urethral sling. I can talk about those in more detail. Treatments for urge incontinence. Medications are always first line. There are a lot of different medicines out there to reduce urgency and frequency. They have about a 60 to 80% success rate. There are some side effects, but they are always the first line treatment. There's something called PTNS, or posterior tibial nerve stimulation. I'm sorry I'm going through these quickly, but I'm running out of time. PTNS, posterior tibial nerve stimulation, is an in-office treatment, does not hurt, has an 80% success rate in the reduction of urgency and frequency. And the vaginal laser is also a treatment for this. There are surgical options. Botox, we heard about Botox from Dr. Bajaj, but there's Botox for the bladder as well. Has a 90% success rate, lasts about 6 to 12 months in the bladder. It can be done in the office or in the operating room. And then there's an actual implant for the bladder for urge incontinence that is done surgically. I call it the pacemaker for the bladder because it's very similar. It affects the way the nerves run to the bladder and improves incontinence, urge incontinence. And then, of course, when I have patients that have mixed, that have both of these, I always ask them which one bothers you the worst, because that's the one we're going to treat first and then get that treated and move on to the other one. So, and that is what we're supposed to do, is treat the predominant symptom first. So if you're more bothered by urge incontinence, I'm going to focus on that, get that treated, and then move on to the stress. All right. And we'll take questions later, but that's the end of my talk. Okay. Hope y'all learned something.
All of you guys that know me know I'm an exercise fanatic. So, I got my weights. Just got to tell you, for the vaginal or the pelvic floor. So, first of all, I want to tell you that I've been treating incontinence and pelvic floor dysfunction for 28 years. Started at OU Medical Center and then opened a lot of different clinics. Now I own my own clinic in Yukon. But I want to give you, first of all, 3 important things to take away today that will, that you can use without needing me. If you need me, I'm here, but I wanted to give you something that you could actually use, take away, use at home, and then if you need me, come see me. But hopefully you won't. First of all, the 3 things are vaginal weights, quick flicks, and intercourse. And before I get into that, I want to talk to you a little bit about the anatomy of the pelvic floor. The pelvic floor is a hammock. Sorry, I'm moving my microphone. A hammock that surrounds the vagina, the urethra, and the rectum. There's 4 specific muscles. They're really long, so I'm not even going to tell you what they are. But those are your primary pelvic floor muscles that keep your internal organs separated and in place. Then you have accessory muscles. Accessory muscles are the ones that just come along for the ride. And they are your abs, your adductors, and your glutes. You can use those, and I'm going to tell you when to use those, but you really want to isolate those 4 muscles. And a lot of women have trouble with this, and that's why I have my job. Because those muscles, a lot of women never learn how to identify them. And sometimes never. There are women out there who never have an orgasm, if you can believe that. And it's usually because they never identify their pelvic floor. The youngest patient I've ever had was 16. The oldest patient I've ever had, 98. And it's all to teach them how to use their pelvic floor. So how do I do that? First, I have to do an internal exam. There are 5 levels. 0 is nothing. You can't do a thing. 5 is, you don't need me because you're so strong, you know where it's at, and I don't know why you're here. Which is never anybody. Ever, 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 ever. So one thing I'm going to have you do right now is I'm going to have, and it's not to get on to anybody. I just want to see if you can identify the muscles. I want you to put your hand just on your abs. Nothing else, just your abs. And then I'm going to ask you to squeeze your pelvic floor. See, nobody else can see you do this but you. Nobody else can feel you do it but you. And now I want you to relax. And then I'm going to have you do 3 quick flicks. Okay. If anybody felt their abs contract at all, that was an accessory muscle. You're not supposed to use those unless you're having intercourse. You bring everything to the room for intercourse. Everything. So, that's how you identify those muscles. So yeah, you can laugh. I've got my weights here. I'm going to let you feel these. Don't take them home because these are mine. Not used, but mine. So this one is the lightest one. This one is the heaviest one. Most women can start out with number 1 or number 2. The important takeaway here too, not only with these vaginal weights, is we've got to use these muscles functionally. Laughing, or it will help with laughing, coughing, sneezing, okay? But we need to do them lying, sitting, and standing, walking, talking to a friend, washing dishes. Put this baby in and walk around the house without your clothes. I mean, loose clothes, because it might fall out. So I'm going to pass these around because I really want you to feel how heavy they are. This one's the lightest. You should probably start with this one. If you can brush your teeth, walk around the bathroom, put on your makeup, do some dishes, fold some laundry, things like that. You will, and hold that in and build from 5 minutes to 15 minutes. Your pelvic floor is going to be so toned, and you're going to know where it's at. If it pushes out, you're pushing down. So you have to pull up and in to get that muscle, okay? So she's already talked to you about stress incontinence, urge incontinence, and mixed incontinence. So this is where I come in. She's identified it. I usually do a question, and identify it too, but then I have to figure out how to treat it, okay? So the first thing I do once I decide how weak your muscles are, then I decide what device I'm going to use. This is a biofeedback unit. This is a vaginal probe. The vaginal probe has electrical stimulators right here on it, or electrodes that will stimulate or give me a number with the pelvic floor contraction, okay? Then it's hooked up to a biofeedback unit. I can set my threshold very low. If you're a 1 or a 2, which most women are after childbirth, then I'll set my parameters down really low so that you can achieve something. If I set them up too high, you're never coming back. But if I set it down low to where you can see that your muscles are working, then every time you come in, I make it a little higher, make it a little higher. It's kind of like playing limbo, but the other way. So that's biofeedback. If I don't feel a contraction and you're a 0, I have another unit called an electrical stimulation unit using the exact same probe that I place vaginally, and it stimulates the muscles. So it jump starts it. So it gets you stronger and going, okay, I know what that is. I know what that is. Then I can go to this, and then I can go to the weights. 3 to 5 visits max, you're done. You don't need me. And that's the way it should be. Yes, I'm here for a lifetime, but you don't need me for a lifetime. I just need to teach you what you need to do. So the next time when you laugh, cough, and sneeze, you can actually pull that pelvic floor up and not push out any urine or gas or anything else. Yeah, I know. And so same thing. The tools are the same for urge incontinence, except I don't need to use biofeedback. I usually go straight to the E-stem. The E-stem, There's a muscle in your bladder called the detrusor muscle, and that muscle tells you when you need to go. This relaxes that muscle. But what I told you a minute ago, very first initially, was quick flicks. So this is valued information. Quick flicks of your pelvic floor tell the detrusor muscle, calm down. I'm not near a bathroom and it's not time to go. It also allows you to build your bladder capacity for urge incontinence. So, and stay-at-home moms, and a lot of us work from home anymore. I don't have that privilege, but a lot of people do. And that's going to kind of serve people into urge incontinence because your bathroom is going to be right there. You're not going to have to use your muscles as much. So you're going to have to build your bladder capacity again. And then mixed incontinence is a little bit of both. The last thing I want to talk to you about, though, is pelvic floor pain. And her and I talked about that just a few minutes ago. Pelvic floor and pelvic floor dysfunction is a huge number of complications. And I'm just going to give you briefly just a couple. I treat women for all kinds of pelvic floor dysfunctions at an early age. Women who are preparing for marriage and they know they can't use a tampon. That's a problem. They'll seek me out. I'll do some dilators, and they're on their way. It usually not very many visits, but a lot of girls, they don't even know that that's available, and it is. And there's a lot of girls who are totally unable to use tampons. We start with dilators, and it's all a very relaxed environment, a lot like this. I try to make it as easy as possible to talk to anybody, because I have a lot of intimate patients and different diagnoses. But and then also pelvic floor pain from either trauma or pelvic floor tightness, and I would use the biofeedback. I know you and I have talked about that. We would use the biofeedback, but in a reverse way. Instead of trying to get stronger, we try to get relaxed. So, and then there's other things like scar tissue, both vaginal and external scar tissue, episiotomy scars, dehisced scarring in the vaginal area. I have 2 patients right now with episiotomies that failed. And so we're treating them for that. Another thing is microscopic tears after any vaginal delivery, any vaginal hysterectomy. And then there's also women who are suffering from tissue inflammation from autoimmune diseases, and their medications and things like that cause tissue inflammation. So the takeaway, or the 3 things that I wanted to make sure I gave you, which were vaginal weights. Don't forget, don't lose mine. Quick flicks to give you time to get to the bathroom, okay? 3rd one, intercourse. We have to know where these muscles are for both our enjoyment and our spouses or significant others' enjoyment. The more you're aware of these pelvic floor muscles, the happier you're going to be. The orgasms are stronger, longer, better. Intercourse helps you with better pelvic floor health because you have to use those muscles. So it makes you stronger. Ask your husband, ask your spouse, can you feel me contracting my muscles? Because that's vital. If you can't, then make it a game. Tell me when you feel it, And I tell you, the more isolation you can get in this pelvic floor, the muscle group, the better control you're going to get in the bedroom. And I want to tell you one other thing, and that is that all intercourse does not need to be a marathon. It can be a sprint. It can be a half marathon. Sprints are just as good as the other, okay? They're all going to push the body parts back where they should be, and they're all going to strengthen your pelvic floor if you use it right. You never want to squeeze those muscles at the beginning. You want to wait for the finale, okay? You can squeeze a little bit, but not too much. Wait for the finale. Okay, that is it. I hope that was helpful.
All right, so I am the last speaker. I'm Dr. Jessica Enix. I'm a board certified general surgeon. So that means I do a lot of different types of operations that include mostly the abdominal domain. However, I feel like I've had some fellowship training in normalizing some of the most sensitive areas of our body. And that involves the pelvic floor, but specifically in my area, it involves the anal canal. No one ever wants to talk about it. And so it's always my goal to make the environment safe, comfortable. It can feel funny, comedic sometimes, but what I need to know is that you can share anything with me. And that's also kind of what really got me interested in being part of planning this, is because our bodies do amazing, wonderful things, but our bodies also do body things that we should not be ashamed of, and we need to be able to talk about it if something is happening. So, today I'll be talking about just common issues that involve our anal canal. And of course, the perianal skin, because it is the most highly innervated tissue, the skin on your body. It is the most highly innervated part of your whole body. I am a surgeon, so I love to operate, but this is a quality of life issue. So I want to give my patients a lot of options that include medical treatments. And then I also want to touch on the fact that anal cancer is a big problem, and an anal cancer is related to not talking to your doctor about something that has changed and popped up in a location that you don't want anyone to see. And I don't want that to ever happen to anyone. So, we're going to talk about some anatomy. This whole show is mostly just slides and videos because, again, it's normalizing what our bodies do. So, as we've talked about in women, it's very, very packed down within our pelvis. You can see our bladder here, our uterus when we still have one, and then, of course, our rectum coming down into the anal canal. You can see this area is not very wide, and that area can be affected by any of the adjacent muscles. Now, imagine what happens when that pelvis and that uterus becomes pregnant. And these are pressure lines to also kind of describe and show what happens, what direction the pressure gets pushed, and why pregnancy, even without a vaginal delivery, is the most common cause of hemorrhoids in women. Now, these are all those muscles that Sherri talked about. They do have tons of fancy names. Do not memorize those. But the whole point is that this is a sling and they all communicate. Urethra up here, vagina here, anus here. A problem in one, muscle spasm in one, will affect the others. So now this is a little talk about continence. I hope the video works. This is actually a video about what our body actually does in order to have a bowel movement. No one ever wants to talk about it, but it is an amazing thing that happens. So when we're at rest, our rectum has this shape that's almost like this S channel. Holds everything in place. We all have little tiny internal hemorrhoids that help us hold pressure to keep everything in at the right time. And then when we can go to the bathroom, let me see if, well, we may not have a video. I was hoping to be able to show you guys the video, but what ends up happening, this section here is the patient's rectum. These muscles drop down while the muscles along the back contract in order to straighten out this area, and then your anal sphincter relaxes in order for you to have a bowel movement. That is a lot of things that happen once a day, once every 2 days, once every 3 days. And it's something that we need to be sure and take care of. And if we're having a problem with it, we need to be sure and have it addressed. Now, this is the area that I'll be mostly focusing on, the anal canal, and it's right underneath that area of the S shape. So first we'll start with hemorrhoids. Like I mentioned, everyone is born with what we would call grade 1 internal hemorrhoids. It's just those little tiny vascular cushions that sit along. This is your sphincter muscle that holds everything in. That way you can pass gas without a bowel movement. You can hold things in if you need to. But it is these things, almost just like varicose veins, that can get large, increase in size, and like if you can think of that picture with the pregnancy, the pressure pushing back into the pelvis engorges these vessels and can cause them to enlarge. And those are symptomatic hemorrhoids. Now, the other thing that I want to talk about is a fissure, because these things are easily treatable without surgery and can be hugely affected by the type of treatment that you undertake. So that's why I wanted to start with medical treatment first. Hemorrhoids and anal fissure treatments overlap, but there's one huge difference. You see me, you see Dr. Singal, I promise you we will talk to you about a fiber supplement. We will talk to you about GI regularity, staying well hydrated, and I also like to throw in the probiotic conversation. We want to have good toileting behavior. It's a pressure thing, so you can imagine your bottom sitting in a circle for prolonged periods of time. So we don't read, we don't take our phones to the bathroom. It's only for business. I am a huge fan of bidets. If I could be sponsored by Toto, the bidet company, I would love it. I have 2 in my home. It makes a huge difference. Granted, these can sometimes be in conflict because they can be very, very comfortable. But it really helps treat and take care of that tissue because it is sensitive. So if we don't want to do a bidet, let's get rid of the toilet paper. Consider things like text pads and wet wipes. Sitz baths, warm baths, and heat help with discomfort and symptoms as such. And then this is so important. Hemorrhoids and anal fissures improve with pelvic floor physical therapy. The thing is that muscle-mind connection. So you have something that is uncomfortable. You have an anal fissure especially, which is exceedingly painful. That causes spasming in the muscles, and it is just this terrible feedback loop that you can get into. And so you tense those muscles up, and then you perpetuate the problem. Now, this is where we take a big, big fork in the road. So most of you will see your primary care doctors when having these initial complaints. Hemorrhoids and anal fissures do all of the things above here. But hemorrhoids should be uncomfortable, they should burn, maybe fire-breathing dragon, but you will never have the sensation of a sharp razor blade coming out of your bottom. That is an anal fissure. So if you go to your doctor, you have that symptom, and they tell you they want to give you Proctofoam, you say no. No, no, no. Proctofoam has steroids in it, which is wonderful for hemorrhoids, but it is just a Band-Aid, right? So it thins the skin, and it actually decreases your ability to heal. So when we're talking about an anal fissure, that is the last thing that we want. So anal fissure is a split in the posterior aspect of the anal canal. It's very important to me because it is lower risk for me to operate on your hemorrhoids than it is for me to operate on your anal fissure. So unlike Dr. Allen, if you come into my clinic with both problems, I will try to fix your anal fissure first with medical intervention. This is the reason why. You may not be able to see the line, but the surgery for me to fix this for you, if all of my medical treatments fail, is I have to make an incision here, and this is a sphincter muscle. This is what controls your ability to hold in your bowel movements. I cut through that. So we have that conversation that if we get here, there is a risk of long-term stool incontinence. So this one gets fixed first. So what I want everyone to take away and also be able to talk about with their loved ones and their girlfriends, if you have an anal fissure, do not put steroids on it. An anal fissure with steroids on it will never, ever heal. No proctofoam, no preparation H, nothing like that. And this is actually exactly what it looks like in the operating room. An incision right here, and then just a nice blade through the muscle. It's terrifying, honestly, for me. Most of the time, the results are very, very good, but we hate getting there. Now, surgery for hemorrhoids. We can talk about that all day. I offer lots of different options. Treatment for hemorrhoids is mostly geared towards quality of life. So if you have hemorrhoids that are causing bleeding, itching, discomfort, we can talk about trying all of our medical options. If we exhaust those, we can do surgery. This is a procedure that I like to call hemorrhoid light. It makes hemorrhoids smaller, but doesn't make them go away. This one actually removes the internal hemorrhoids without removing the externals. The thing that's nice about internal hemorrhoid treatment is it's easier to recover from and less pain because I am staying above the innervated part of the anal canal that we talked about has all of those hundreds of innervation tips. And then this is a traditional hemorrhoidectomy. I perform these as well. This allows me to remove both the internal and the external. Externals are quite painful though, and it has to be worth the recovery time to undergo the surgery. Now, I did want to touch on this, like Dr. Parker talked about in the beginning of the symposium about cervical dysplasia. Now, the same virus affects the anal canal, HPV. The most common types that we see will actually cause anal condyloma. Anal condyloma can be easily treated with chemical treatments or removal. I offer multiple different options in the clinic as well as in the operating room to be treated. However, this is the thing that I want everyone to be able to talk about. Because if someone has something on their bottom and doesn't have it looked at and it grows, it can become anal cancer. And I don't have a picture of her, but Farrah Fawcett died of HPV-related anal cancer. And this is something that we can prevent. We know that it's associated with HPV 16 and 18, but we also know that it's associated with almost 91% of all anal cancers have some form of HPV. So it's very important that if you've ever had an abnormal pap smear, that you pay attention to your body, look at your pelvic floor, and if you have any questions at all, have a rectal exam. Have someone you trust go in and see your doctor. And I am a huge fan of Gardasil. Gardasil makes a huge difference, decreases your risk of HPV-related cancers. So something that I do offer in my higher risk patients is I am actually doing what are called anal pap smears. Now, this is for patients that we know have not cleared HPV higher risk strains. This is also for people that participate in anal receptive sex. And then, of course, anyone in the homosexual population that has multiple different partners. And this actually looks a whole lot just like your pap smear. Whenever you go into your doctor's office. So I just wanted to hit home that our bodies are strong, they are complicated, and we just need to be able to talk about it when anything is going on. Thank you.
Okay, ladies, any questions for this panel?
Asking for a friend. For fecal incontinence, I know some people have that problem. Do they have, like she passed around the vaginal weights, do they have anal weights that help somebody with that?
So we don't have anal weights, but fecal incontinence can be drastically improved with pelvic floor physical therapy. Again, it has to do with that mind-muscle connection, but it is a quite difficult thing to address. Now, I do get that referral. Sometimes it can be caused by other things that I can address surgically, but if it is a true fecal incontinence issue, I have a very wonderful colleague, Dr. Christina Booth, that's a colorectal surgeon, that is great at treating this. That video I was trying to show was actually, it's called an MRI defecography. And it specifically looks at the muscle function involved in someone that may have stool incontinence.
Other questions? Yeah.
So ordering the anal pad, if you're saying that it is like yellow, do you have to specify that it's an anal pad? Do you have to order it different?
So there is a whole process. This isn't something because further studies do need to be done to prove that it is actually effective. I offer it because I take care of a lot of high-risk patients and I take care of a lot of condylomas in my clinic, but I did have to design a process in which my pap smear goes through my pathology lab and then goes off to DLO. And then that way, if I get an abnormal, I take them to the operating room where I do something called high-resolution anoscopy if I don't see a lesion. And then I biopsy areas, and then we compare the pap to the biopsy. So hopefully, in the future, we'll have something that's more translatable.
One of the very few people who are doing anal pap smear in Oklahoma. Is that correct? Because it's been so hard to find somebody who does it. So especially in HIV population and immunocompromised patients. So refer to you because you're working on that process and have stuff.
Any other questions?
Yeah, I'll come back there next. Yeah, go ahead.
I have a question for Sherri on the weights. Is that something that you can just start on your own, or would you need to be seen by you first?
That is a great question. You can start it on your own. You can, I've ordered them on 2 places, Amazon, just at $50, eBay, $20 to $30, and they last for a lifetime. That's a really good question. So I would say don't just Google vaginal weights and you'll get the intimate rows. And believe me, we've tried them. We've tried them all. So these are the best because they're silicone. You felt the gripping about them. You can actually grip. Don't use any KY jelly or anything. You don't need any of that. But anyway, yeah, the intimate rows. Google it first. It'll take you to the intimate rows. Then go to Amazon or eBay and put in that. Intimate rows, ROSE, and then put in vaginal weights. Okay.
Okay.
My question is about the Gardasil vaccination. What's the recommended age range for people to receive that? I mean, I know they give it pretty young, the pediatrician will, but what's like?
So my slide has it. You can get it between 9 and 45. So there's a large age range there. We know that if you get it while in your teenage years, you should only get 2 rounds of it. Gardasil 9. So let's say Dr. Parker had mentioned the vaccine came out when we were in college or med school. That's what it was. We were in med school, and I believe it was Gardasil 4 at the time, and now it's like up to like 9 to 12. And that treats more ranges of the HPV virus itself. Now, when we're older and we get the Gardasil vaccine, the recommendation is to do 3 rounds, and it all has to do with how our immune systems have developed. So 2 vaccines because our immune systems are so active when we're young, usually adequately vaccinates us. As an adult, you will need 3. Even if you have contracted a high-risk strain or have been diagnosed with a strain of HPV from condyloma or from an abnormal pap smear, getting the Gardasil vaccine will still help your immune system to attempt to clear the virus or to also make sure that you don't contract any additional viruses.
Okay. You have another question. What if you are over 45?
Well, the FDA hasn't come out with recommendations. I will say, so this is something that is very unique about many of the physicians and providers that we have here, is that we're in private practice. And so also having the ability to have that conversation and say, well, we can attempt to submit this through your insurance and see if we can get approval. When we get outside these ranges, it does get more difficult to get it covered. I, just because I do so much colon cancer screening as well, have a tendency to say we need to prevent, reduce, and treat in healthy patients no matter what their age. And we know that patients over 45, and especially those patients over 70 that have lost a partner and are back in the dating field, is the highest growing rate of sexually transmitted diseases, which would also include HPV.
Well,
You can ask the question.
Can you just touch again on what you said between the hemorrhoids and the anal fissure? Like, what are you looking for the difference? Like, what symptomatic differences between those two, so you know which one you're dealing with and where you need to go see somebody about it?
So the biggest symptom is going to be the pain difference because it can get really tricky. The thing that anal fissures do to us that is the worst thing that makes it so confusing is something called a sentinel pile can be created. And what that means is that that area has split open right along your sphincter muscle. And we've had enough trauma either from pelvic floor spasm, from constipated bowel movements, that it just keeps getting re-traumatized and it develops this lump of scar tissue. That lump of scar tissue can get mistaken for a hemorrhoid, and I see it more often than I'd like to. So the big difference is the pain. Pain with a bowel movement that feels like razor blades coming out of your bottom should not occur with hemorrhoids. Hemorrhoids will burn, they will cause pressure, they are uncomfortable. Sometimes you feel like you're sitting on rocks, but it is not razor blades coming out of your bottom. And that is the big, huge difference. A good exam will also outline that. However, someone with an anal fissure, you should never do a rectal exam on. Like we talked about, all of these muscles communicate. So all I simply have to do if I suspect it in clinic is I press those muscles right along the edge of the anal sphincter, and it immediately sets off pain. Hemorrhoids don't do that.
Ladies, thank you all for coming today. We're all super happy that we got to do this. We absolutely plan to do it again. We want to thank each one of the physicians and the other speakers who came. I think it was really important. I think we're super empowering women is what we really want to do. You should have resources to everybody who spoke in your bag, but if you need anything at all, you can call up here. We have cards and different information.
Wanted to tell everybody that we have what POWHER is all about up over there with our core mission statement and core values if anybody wants to take this. And then we have the sheet. If you want more information regarding our future projects, please sign up on this sheet of paper.
Thank you all for taking the time to come out and spend your Saturday morning with us.